Okay, I guess I
Yes,
am.
can hear you.
Record nimeelewa. It's a bit
Nice.
nostalgic. Yes. Good evening, everybody. Welcome to the KNHUON webinar. This is the Social Health Insurance series, and it's a three-part series. So we'll be having today an overview of what SHA is about, and who better to speak about it than the CEO of SHA, Dr. Elijah Wachira, together with Dr. Elizabeth Wangia, who has been the team lead from the Ministry of Health in ensuring that this process goes through. So in case you have any questions, please post them on the Q&A. We will try and address them as much as possible. If it's answered within the process, we'll be able to skip through. Dr. Wachira, karibu sana. It's a pleasure having you on this platform. I know it's a heavy pillar that you are supporting in healthcare, the pillar of healthcare financing, and as the CEO of NHIF, you are the best person to tell us on how we have been in the past, because NHIF has been there for 57 years, and now we're moving to SHA. And on 19th October, 1 year will be up. So we welcome. We hope to have a better understanding of a lot of the information that has been unpacked in a very simple manner. Karibu Daktari. Mr. Elijah, sorry, Mukikwa Health too. We have a tendency of calling people doctors. So Dr. Elijah. Karibu.
Sana, good evening, everyone. Thanks for tuning in. Can you hear me?
Yes.
Am I audible?
Yes, you are.
Thank you very much. Thank you, everyone, for tuning in to this webinar about social health insurance. I think in a very summarized manner, NHIF was born in 1967 as a small department in the Ministry of Health. It was able to grow from that small department into an organization where employees could contribute for their accommodation, bed-only charges to be paid by the fund into hospitals. It further grew and opened up its services to non-employed people in the informal sector who, as at last year or even as at now, are paying 500 shillings every month to be able to access service. Then it opened its services even further because it started running enhanced schemes. It at one point had more than 90 different schemes it was running. While this expansion was very good and was intended to serve the needs of our fellow Kenyans, a number of limitations were established. Number one, which is very important, it was still serving only a select population. Only the contributors were able to purchase service. So to that extent, anyone who was not a contributor was not able to access service. Then number two problem was these enhanced schemes. On many occasions, the pricing of these schemes that were run by NHIF was not commensurate with the claims trends. And all these funds were put in the same basket. What this one ended up doing to the fund is that the fund gradually started paying out more than it was receiving, and in the process, compromising health standards for the various contributors. And I'm aware a number of providers, we could be having a few on the platform, will test to this, because everyone's in a while NHIF members have accessed service, NHIF has on a number of occasions not been able to pay on time. So to address this and other concerns, including the fact that the ICT systems in use at NHIF were now becoming archaic. People in the ICT field call these ICT systems legacy systems. Then a wise decision was made where, number one, a new entity that was going to offer service to all Kenyans, regardless of socioeconomic status, religion, color, age, and everything, was built. This culminated to be able to offer social health insurance. If I don't achieve much in this talk, please take your pen and papers, because I would like out of this session for us to have a very clear distinction between she, shia, chief, and sharp. So the subject that we are discussing of enabling access to universal health care for all is social health insurance, which is SHI, S-H-I, social health insurance. Now, to enable social health insurance to be implemented, a social health insurance bill was created, and it was enacted on the 19th of October, 2023. So this now moved from the Social Health Insurance Bill to Social Health Insurance Act. Social Health Insurance Act, SHIA, created an organization that will deliver social health insurance in Kenya. And the organization that was created by this act is called Social Health Authority. This Social Health Authority, for purposes of this discussion, so we can understand it very well, will be managing 3 funds. Please look at the 3 funds as departments the organization that is called Social Health Authority. Primary Healthcare Fund. Primary Healthcare Fund will be fully funded by the central government. It will finance access to healthcare services in dispensaries and health centers. And it is important for me to emphasize here that these health centers and dispensaries are private, public, and faith-based owned healthcare facilities. So level 2 and level 3, the financier will be exchequer, and the fund is called Primary Healthcare Fund. Then we have a second fund that is most popular amongst Kenyans. And this second fund is called Social Health Insurance Fund. Everybody is calling it SHIF. SHIF will be financed by 2.75% of the incomes of every Kenyan. So if you are on payroll, 2.75% of your household income is calculated and will be remitted by your employer on a monthly basis. If you are not employed, a means testing tool will be applied to your lifestyle and your income will be determined. 2.75% of your annual income will be established, and that will be the premium payable by either the contributor or a sponsor, who could be the national government, the county government, or any other sponsor. It is important at this level for me to say that for indigents, people whose income is below food poor, then the government, through the Department of Social Services, will be able to apply the means testing tool on them, confirm that indeed they cannot afford the premiums, and then these premiums will be paid for them by the Department of Social Services. Then we have people who are in legal custody, people who are incarcerated in jails. Then those ones, the Department of Correctional Services, prisons, will settle their premiums. The minimum payable premium of the 2.75% of income is 300 shillings a month, totaling to 3,600. There is no maximum because we want everybody to pay the same proportion of their income. Then we have the third fund, Emergency, Critical and Chronic Illness Fund. This fund is giving people access to emergency services. Access to emergency services is a constitutional right for every person. And therefore, as long as you are in this country, the government will finance emergency evacuation for those in listed emergency situations, and will take that person to the nearest health care provider and pay for the first 24 hours of service before the person, with which time the person should be resuscitated, and service will be, no, let's first talk through and then I'll give the slides later. Then service will be offered from shift immediately after the 24 hours. In a nutshell, the major differences between NHIF and SHA are: number one, SHA is offering service to everyone, because as long as you are resident in our country, you have access to free emergency service and care up to the first 24 hours. Number two, as long as you are registered, you have access to free primary health care service up to. You have access to free primary health care service. And then for those that are paid up, you will be able to be referred if your condition is beyond what our primary health care level 2 and level 3 facilities can offer, to levels 4, 5, 6. I think in a nutshell, that is what I would give as an introduction. Then maybe we can go to the next session. Thank you.
Thank you, Bwana CEO, for that comprehensive introduction. I believe you've really compacted the message, and you've really summarized the problems that SHA is solving, the fact that we are actually actualizing this. So with us is also Dr. Elizabeth Wangia. As I mentioned earlier, Dr. Elizabeth Wangia has been the technical lead in spearheading this process. Dr. Wangia.
Yes, Dr. Amina. Yes, thank you so much, Dr. Amina, and for the organizers of this webinar. the CEO has given an overview of what SHA is all about and a bit of a background. My role mainly for the purpose of this webinar was to look at the benefits and tariffs. The first thing when people enroll into whatever form of insurance, whether it's life, motor vehicle, health, the first question they ask is, what are the benefits? So as a ministry, we knew that this is quite important, and therefore we began the process of developing the benefits package. So first of all, you develop the benefits package, then you come up with tariffs. And tariffs are basically, the price attached to each intervention. The process of development of the benefit package is outlined within the Social Health Insurance Act and the attached regulations. There are three considerations. Anytime one wants to develop a benefit package, there are three things to put into consideration. The first thing is to look at what is the, so for the tariffs, what is the cost of the intervention? This is the benefit package and tariff. First of all, you look at the cost of interventions, then you do an actuarial analysis, and finally, you have to look at the budget, especially for social health insurance. You have to look at what is the available, envelope to cater for the services. When looking at the benefits, in this case for social health, for the social health insurance, we started by the whole universe of benefits. We have in Kenya, we have what you call the Kenya Essential Package for Health. So the Kenya Essential Package for Health basically enlists the various services and interventions by level of care, that is from level 2, level 3, up to level 6. What are the interventions that are available and considered essential? So that was our starting point. We looked at the essential benefits package. And when we did an estimation of the essential benefits package, we were actually getting figures of around 950 billion. So the next question to be asked is then, now that you have the essential benefits package, and it's that much, and I'll also touch on how we got to say that around 750 billion. Then the next question is then, how do we prioritize? We know that in every situation, even our own salaries, we have to prioritize. So upon prioritization, we used quite a number of tools, including one tool from WHO called the DCP3 tool that really tells us what are those key interventions. Now that we had the whole universe of interventions called Kenya Essential Package for Health, through the DCP3 tool, we were able to see what are those interventions that are considered really critical for low and middle income countries to achieve UHC. And we went into further prioritizing based on that intervention. Thereafter, of course, we then did what we call the yield. I know the many people we have interacted with know by now what the yield is, because as I said, for you to develop a package with tariffs, you must know what is your budget, because you cannot put everything in the basket, and a package is definitely meant to be progressive. So we did our estimations, and when we considered the critical services and got our figures, we were able to see then with these figures, what will people contribute for them to be able to achieve this package? And that's how we landed on the 2.75 for all people within the formal and informal sector per household income. And therefore, with that, we now started, putting detail into the package. So as in the process of developing the benefit package, of course, there are certain critical things that need to be put into consideration. One is that you must know your population in need. For instance, if you want to cover hypertensives, you must know what is the prevalence of hypertension, and of this prevalence, how many hypertensives actually know their status that they are hypertensive, because you could have a certain prevalence, but not many people know that they are actually hypertensive or diabetic. Then you have to look at that, because those who know are the ones who will come and seek service. So based on that, we can also actually know then that this is the estimated number. And based on even data that we collected from literature, and even from, of course, literature studies and even prevailing data, we were able to know what does it take to treat a hypertensive, say in a year. What will it take to treat a hypertensive? That means on average, you'll have done your 3 monthly tests or 3 monthly reviews, monthly medications and all that. What is the average treatment per year? So if we got, say, 1 million, we realize that we have 1 million hypertensives who know their status, and treating them is an X amount. Therefore, for us to cover hypertension, we estimated that hypertension then will be that number of people multiplied by the cost of treatment per year. So we did that for all the diseases that we put into consideration, whether they were even immunization, family planning, normal deliveries, and we were able to get the estimated costing for that. Now, the other thing that we also need to know is that as we get the costing, or the costing, or I would say the tariffs, the next question we ask ourselves then, how do we pay the provider? Because the way you pay a provider has different incentives. If I say that all maybe payment methods is fee for service, and fee for service means it's actually what most people know in the private sector, that you come to the facility, you are charged for consultation. If you are doing a lab, you are charged for that lab. You probably are charged for the supplies. You need, a glove is used, the glove is charged, all that. So that method will actually be the ideal. But then in the situation where, say, we have, like, for instance, in the case of social health insurance, and even in private insurance, there are different incentives. So the provider or the clinician can decide to do as many tests as they want, even if maybe, I would say, quote unquote, they are not very, very necessary. And of course, we always say in the spirit of evidence-based medicine. Yeah, so maybe I have a flu. I can clearly, from the clinical symptoms, I see this person has a flu. But since I know that I'll be paid for every service I give, I will send them for a lab, for a hemogram, let's just check this in case. Let's just check your lipids in case, all that. So that is the incentive. And as a social insurer, you cannot afford to lose actually resources in that way, because now that is inefficient use of resources. So basically, as we set the tariff, then the provider payment mechanism really has to be put into consideration. We know that NHIF mainly used to use capitation for primary health care. We know that capitation has limitations. So maybe for those who don't know capitation means that a certain amount is assigned to individuals. Like I would give like the NHIF case, an individual will select a facility, and a certain amount is given per head, or per belly button, as we used to like putting it. And these resources are given to a facility as a whole. And the assumption is that not everyone who has selected that facility will actually seek care. So the problem with this, so the advantage of this method is that then the clinician, since they know that additional testing and additional interventions won't earn them more, they tend to be more rational with their decisions, and therefore only make the only critical decisions for the patient. But on the flip side also, a facility can decide, now that I'm not given extra money for all these interventions, they can just do triage, say, probably take your blood pressure, blood sugar or something like that, and that is it. So there are all these incentives for the provider, and also for the, especially for the at provider level. So so we have also other provider payment mechanism. There are those ones that are called case-based. And of course, like for us, one key method that, as I indicated, we will not use as a social insurer is the fee for service, except for specific interventions that you can clearly pinpoint to. So basically the process of developing the tariffs then we had around 6 processes. The first one was data collection and analysis. As I said, from literature review, our team did costing, especially for primary healthcare services, and were able to know what is the cost of offering primary level services. Once you do that data analysis and decide on the package, then the next stage is tariff setting. Then once you have set the tariff, then we do provider engagement. Many times the people who we engage the most when it comes to tariffs are the providers, because at the end of the day, these tariffs will apply to them. And the question will be, do they make business sense to them or not? And therefore, if they don't make business sense, two things could happen. Is one, they could decide not to offer the service, or they could decide, or they could decide not to offer the service, or they could do what we call upcoding. So upcoding means that I have a normal delivery, but because the cesarean section is more expensive, I claim that all of my deliveries were cesarean sections. And in as much as maybe at that level of the provider, they may not think of the impact of upcoding, but at the end of the day, when you think of the whole research in terms of data analysis and all that, it then gives a skewed picture. And I'm not saying that that's what happened to this country, but I know in Kenya, the rate of cesarean section, in fact, there was an article, was it last year? There was an article that said that I think our cesarean section rate had gone up, I think, to around 20 or 25%. And probably that could be one of the reasons, because we know that there have been, Leader Mama has been there have been maternity packages, and if the rates are so poor, then people tend to think of a higher rate. The common one that I know people fall culprits to, maybe even if some surgeons are here, someone wants a circumcision and they just say, okay, phimosis, which is a medical condition. Then you end up paying for the phimosis, but it was just a circumcision. So probably at some point, when you're doing your analysis, you may be thinking, in Kenya, people really have this condition, but in the real sense, it's because the clinicians were upcoding the condition. So after provider engagement, and we had quite an extensive provider engagement, you cannot develop a benefit package without provider engagement, associations engagement, because at the end of the day, even at policy level, we cannot purport to know all the processes that happen for every condition in the country. So we really rely on guidelines provided by either the associations and the like, so that at least we can make reasonable sense. And therefore, without information, it's very difficult to develop a package or say whether we can afford it. A lot of experience I've got during this process is someone writes you a message and tells you, I want this service. Let me just say, why aren't you offering crutches? Then I just ask a simple question. How many patients need crutches in this country? Which conditions are documented that will need crutches? If you say maybe accident victims need crutches, not all accident victims need crutches. Of all the accident victims, first of all, do we know the accident victims? Of all those accident victims, how many need crutches? How many would need crutches, and for how long? Because maybe some will need crutches, some will need a wheelchair, some, so now just delineating all that actually is quite some task, which really, I know a lot of times I had to we had to actually send people out with this information, with this long template, and tell us how many people need this, of which condition, how long, what is the cost, and all that. So the good thing is that moving ahead, the law provides for a benefit advisory, benefit package, benefits and tariffs advisory panel. So the work of this benefits package, benefits and tariffs advisory panel will be to do exactly this throughout the year. If today you wake up and say, oh, I need CCLAs are have not been covered and all that, so what do we do? Then you present your intervention, give the justification, give the data, say these are the number of CCLAs. Of all these CCLAs, these are the ones who will need bone marrow transplant at one point in time, and who are these who don't need, and all that. Then based on that, we see, yes, can we afford this, or the cost of that? Then later on, when you look at the overall budget, then you can say, okay, yes, then we'll afford that. I talked about provider engagement. Then the fourth stage will be around tariff recommendation, because we had quite some good actually engagements with the providers. We have we have the CHAC, which are the Christian community, who were really helpful when it came to this engagement and even tariff recommendation. So there are things that could happen. So for us, as we look at a tariff, we have our tariff as a social health authority. But then we realize or acknowledge that in every situation, people offer different things. So our tariff for us, we say if our normal delivery is this amount, whether you'll go to Nairobi Hospital or you'll go to Ruai or KNH, 30,000. Then if maybe for the private facilities who see that is not adequate, then we allow them to we allow the patients to copay. So for us, we'll say this is our commitment. Our commitment is 30,000, but because we also acknowledge that people go to hospitals to get different things, there's also comfort in hospitals, and I don't think that the social health insurance would pay for, say, a couch or what. We're not saying that people should not be comfortable, but for us, we are looking at the intervention. What does it take to offer that intervention? And therefore, we acknowledge that for one reason or the other, there could be a reason for copaying. And then also, so basically that is the tariff. Our tariffs are flat like that. 1 week ago, we managed to do a national validation for our tariff, and this week we'll be doing gazettement of the tariff. So that is just the process. Maybe also, Dr. Amina, you can guide whether there's an interest in maybe knowing what the tariffs are, or what the package is all about. This was just basically the process.
Yeah, thank you, Daktari, for the summary. For us to understand what is benefits and tariffs, because majority of us do not have a good understanding of it. What I would suggest, Daktari, if you have if you have a short slide on the benefits and tariffs that are going to the benefits that SHA is going to provide together with the tariffs, and then after that we can go into Q&A.
Okay.
Is that okay?
Okay. That's fine. I can quickly, just give me a minute to project it. Can project the benefits and
and what we can do in the meantime is perhaps answer 1 or 2 questions that were directed to the CEO. Dr. Wachira, you're still with us?
I am.
Yeah. So we have a lot of questions in the Q&A, and maybe I tackle the one with for registration. When I register for SHA, do I then stop contributing to NHIF? What does it mean registering on SHA?
Let me take that one. When you register for SHA, you do not stop paying for NHIF because NHIF benefits will be available up to the 30th of September. So if today is 10th of September, you have another 20 days. So for this month, the financier who will pay your hospital bills is NHIF. But with effect from the rollout of the SHA benefits, which is anticipated to be 1st of October, then you will pay for SHIF, be able to access SHA benefits. I hope that is clear.
Yes, that's clear. To me, we'll know from the Q&A if the thing needs further clarification. So, yes, Daktari, I can see your slide is on, so we'll let you continue and finish, and then we can start the Q&A officially.
Yeah, so this slide basically just tells us of the process, what I indicated, how we identified the services, costing of the package and all that, getting the data, till we computed the cost, determined the yield, optimized the package, and validated with stakeholders. This one actually just emphasizes on what the CEO talked about, the 3 funds, which are now clear to all of us. So the benefits financed by the primary healthcare fund include outpatient services, meaning that if you go to an outpatient facility, you should be able to get the general outpatient services. You have a cold, you have a flu, you have, stomach problems. You should be able to get that service at primary level. And primary, when you talk of primary level, we're talking about the dispensaries and health centers, what we call level 2 and level 3. So at level 2 and level 3, we also have inpatient services. We know there are health centers and even some dispensaries who have, that one bed for the emergency. So overnight, we cater for that. Then screening services. Screening services will also be covered, and specifically screening for hypertension and diabetes. I will touch on maybe we had an expanded screening package, but we had limitation in resources. As I said, you have to look at the budget. Then optical services, that means if you have any eye conditions, include, eye conditions, they are catered for under the primary healthcare. So the scope of cover is as I indicated. So when you go to a facility, you should be able to have the consultation, basic lab investigations. We know the lab investigations at primary level. Even most of the time, they are mainly rapid tests, but there are also, of course, the others. Imaging, prescription medicines, vaccines, outpatient procedures, management of mental conditions. If you have mental conditions, basically when we are saying if you go to the outpatient, we won't limit the condition or the diagnosis the doctor will give you. Now, when you talk about a tariff, as I said, it's the payment. Here we will be working on what you call capitation. We had, and this will, of course, eventually progress later to another payment method. But for now, as we start off, we'll start off with capitation. And capitation will be at 900 per person per year. Remember, we say that at primary level, we did the costing of services. One thing that we need to realize is that without costing of services, it's really difficult to know the cost of a service, because one person will be charging this high, another one, this high. Then, so we are saying at this level, so long as you are a registered member of the Social Health Authority, so long as you register, you don't have to pay. But of course, we want to hit 85% registration and payment. But we are saying at this level, so long as you register and you are known to be a Kenyan, because the whole point of registration is to confirm that you are a Kenyan and that you are not treating, foreigners. Otherwise people will be coming in from even our border countries to seek services, and yet we have not planned for them. So under optical services, we are still talking about eye health education, eye tests, like visual acuity tests, and also refractive errors through eyeglasses. And this one, we are working with 1,000 per household, per beneficiary. Then we have primary health care inpatient services. This one, I think I had mentioned that, so long as you're admitted, we pay what we call a daily rate of 2,240. And all this is based on the data that we collected. Like we knew what is the average length of stay of a patient in the ward. And based on that average length of stay, we also got the estimated cost within that average length of stay and did that per day. And I know that there are days probably that you spend more. Maybe the first day you're doing a lot of labs and all that, but probably after that it will be a matter of monitoring and continuing with the medicines so on. These rates are usually on average, and the limit is also on 80 days. So screening services, this one I did even indicated that screening will be mainly for diabetes, hypertension, while the screening for the cancers will start in year 2. When at least, it's always good to be practical instead of starting so many things at the same time, which we may not be able to sustain. You'd rather start, slowly and progressively. So of course, that's where we are. So for the social health insurance fund, those are the benefits: outpatient, inpatient, maternity, renal care, therapy, mental illness, surgical services, oncology services, medical imaging, and overseas treatment. So for outpatient services, to start with, we'll be mainly catering for 4 main conditions: diabetes, hypertension, sickle cell, and asthma. And these are rates, tariffs per year. For inpatient care services, those are the rates. So basically, if you go and seek a service, this will be the rates per day, what we call daily rebate or per diem. It's not the usual per diem that we know of, but yeah. So maternity, newborn, and child health services, we have right from the spectrum, right from conception till delivery, because we are looking at antenatal care and delivery, whether it's normal, cesarean, postnatal, immunization for the baby. In case a baby maybe complicates and needs to be admitted, then that baby will still be covered immediately under the mother or under their parent. For once, we are catering for anti-D serum, which was not there. We know anti-D is actually around 6,000. So it was almost impossible to offer this within the package, say, of Linda Mama, where for dispensaries, we used to reimburse 2,500. And the anti-D alone is around 6,000. So for once, we'll cater for anti-D for rhesus negative mothers. And those are the rates for the normal and cesarean section. Renal dialysis, one thing that I would like to say, the renal patients are actually celebrating, well, not because of their condition, but because this time we know that there's been that need to have, say, a third session if a nephrologist deems it necessary. So in previously under NHIF, we were limited to 2 sessions of dialysis per week. But now we have brought in the third session when necessary. Then for the transplants, and mainly we know that we do the kidney transplants, though there are other transplants. We have corneal transplants, liver transplants, but specifically, I'll just touch on the kidney transplants. For kidney transplant, for once we'll cater for the workup for the donor, the blood workups for at least one donor. Then after that, we also cater for the surgery of the donor, because for you to donate a kidney, of course, you need the surgery. Then also the surgery of the recipient. And we will also cater for the post-transplant immunosuppressants. And the reason why we are heavily investing in this dialysis is in the transplant is because this dialysis is one of the interventions that actually consume the fund. So you can imagine if you are being paid for 21,000 a week, that means per month the fund has to pay 80,000 per person, and therefore per year you're close to 100,000. So you can imagine, and dialysis is endless. Like I mean, you can do dialysis for of course it will have to be for the rest of your life unless you get a renal transplant. And therefore the investment in transplant is actually worth it, because within 3 years we'll have no equalized, and starting I don't want it to sound bad, but I would say quote unquote, our return on investment will be 3 years. Actually, it's around 2.5 years if we do renal transplants. Then I think this one I touched on this, the transplants. Then mental wellness is also catered for, and specifically here, allow me to touch on the drug and substance abuse, where we cater for at a limit of 67,000. We know that there are centers that cost up to 400,000, but then for us, what we can cater for is 67,000 based on the budget limits. Then of course, if there is the need for co-payment, the patient will co-pay. The scope of surgical services, we have the way we have put the tariffs for surgical services. It's based on a bundled, it's more of bundled. So we won't go and start counting how many minutes you are given oxygen in theater, how many hours did you, so how, rate per hour. No, for us, we say, what is the cost of an appendicectomy? And we pay it as a lump sum. So that is it. And we have some access rules for any insurance. There has to be the small print. Even in private insurance, it's just that maybe people don't read the small print, as we are seeing it allowed. That there we have the small print in all this, and some of the small print is usually just to deter harmful behaviors. Hematology and oncology services for cancer. Also, cancer patients will get some reprieve with the social health insurance, where this time, previously, we were not catering for diagnosis. So what could happen is, for staging, let me say not diagnosis. So previously what could happen is that you could be diagnosed, maybe you have a lump or something, yes, and ultrasound is allowed. Then that is catered for, but then now staging of the disease, now further tests to say, are you stage 1, stage 2, stage 3 was not catered for. So we had diagnosis, then we had treatment. So in between here, patients had to either look for resources to fund that. But now we are saying both the diagnosis, staging, and treatment is allowed up to a limit of 400,000. So whichever cancer you have, the limit is what matters. So whichever protocol that will be used, and I know Kesho gave us a list of all the protocols per cancer, and those will be actually put within the system, so that we know that for this cancer this is a potential protocol, and therefore we know the estimated costing for that. Medical imaging, MRI, CT scan, angio, Dopplers, mammogram, fluoroscopy, echo. PET scan is actually under oncology services, so we also have rates for that. Oral health services, we have the scope of cover is there, where we have screening, consultation, extractions, ART, dry socket debridement. Yeah, now that's not my really, my area, but we have all those that are covered. But the limit is 2,000 per household. and also for the areas where we have dental services available. Then overseas treatment, we are saying that overseas treatment, one will only cater for conditions that are not available in Kenya, and they'll be at around 500,000 per person. So for the emergency fund, right now, the main area that we'll be looking at, this is the range of services of benefits, but because of budgetary limitations, our main focus will be looking at comprehensive emergency services. That is a new service that was not there. So ambulance evacuation and stabilization of the patients within 24 hours will be catered for. Beyond 24 hours, the expectation is that if you have an injury, if you have another insurance, it will kick in. If you have social health, if you are a paid up member of SHA, that will kick in. Otherwise, for now, we want to cater for emergency services. And I know health generally sounds like everything should be an emergency, but for the purposes of this fund, we describe emergencies as conditions where if no interventions is done, I would say more or less immediately someone risks losing their life. So and that's why we say we pay for interventions that will stabilize someone, not really, make them recover, ensure that they have recovered, but stabilize them to a point of where we can say that this one can now live beyond, and that's why we say 24 hours. And this one will cater for services right from level 2 and level 6. Maybe you have eaten nuts and you are allergic and you didn't know, and you go into whatever anaphylactic reaction. You can go to your nearest level 2 because that is life-threatening. You can go to your level 2 facility, and the emergency fund will actually cater for that. And we have fee for service for different conditions. And this also includes for anti-snake venom and anti-rabies. I once worked somewhere where there were so many dog bites. So I guess those ones will feel relieved as they give the anti-rabies. For critical illness, this one will be covered at the normal rate as the normal inpatient, and it's solely because the budget was restricted. Of course, if once the fund grows and it gets into maturity, we actually know what the right rates are. But then for this case, any additional will be the patient will co-pay. Same with palliative services; it will be the same, the same reimbursement as inpatient. And for the assistive devices, this one will also be rolled out in year 2. So cosmetic exclusions include, this is my last slide, I think. So exclusions will include cosmetic procedures, treatment by chiropractors, assisted fertility, vaccines other than those by KP, products out of the Kenya Essential Medicines list, weight management drugs, medical costs related to research, epidemics and pandemics, professional fees for medical personnel over and above prescribed rates, expenses related to diagnostic equipment, including but not limited to things like glucometers. So, I mean, if you're diabetic, we'll just treat glucometers. Any other procedure or intervention not listed in the scope of the benefit package. For the vertically financed programs, we acknowledge and we know that the good thing is that most of the donors, at least for the main ones, like for instance, even vaccines and all that, we know what are the outer years, I would say outer years finances. And therefore, this one, since they are already financed, then we won't finance. Because remember, if you put it in the benefit package and cost it, it means that a facility will draw a claim. But then now these ARVs have been given, say, or antimalarials have been given free of charge. So the facility cannot really lodge a claim on that, but we acknowledge them, and we know that over time we need to absorb these services. Yeah, so I think that's where I am. That's where we are. Sorry, it took a bit of a long time. That's why sometimes I I'm usually hesitant to present this, but nonetheless, I'm glad that I did. I hope that it has shed some light to the participants. Thank you. Back to you, Dr. Amina.
Yeah, thank you, Daktari. Thank you very much. I believe the slides were quite helpful. We could be able to visualize the tariffs and know the pros and the cons. So I'll just jump straight to the Q&A. I'll summarize some of the questions so that we can have comprehensive, because there's a lot of repetitions. So Dr. Elijah, first question would be to you. What were we envisioning when we wanted to change it from NHIF to SHA? What informed the changes, and what is the current situation with the current legislation? Over to you.
Thank you very much. The vision was and is still very clear to ensure access to quality healthcare that is affordable to all Kenyans. You realize that a very small population of Kenyans had access to health insurance, something below 20%. When you are insured, your expenses are predictable because the premiums are known. But when you have to pay a hospital bill out of pocket, then this is partially, one, not predictable, and many times very expensive. So it would be very nice if all Kenyans do not have to pay the hefty medical bills, but will have to pay affordable premiums, which are as low as 2.75%. Can you imagine a world where you will not be a member of a WhatsApp group telling you to fundraise for medical expenses? That is, in very simple terminology, the vision of this. The second portion of the vision is where we shall use ICT and artificial intelligence to be able to transact a lot of healthcare financing transactions so as to enhance efficiency and accuracy of record. Again, we are investing in this digital system to be able to ensure Kenyans get prompt, accurate, and efficient service. Now, current situation, we all are aware that in the legal environment, there is a team that had gone to court to question how legal it is to have these acts around. And when they went to court, a judge first declared the acts unconstitutional. Reading through the judgment, the judges applauded the noble objective of ensuring that all Kenyans contribute to a pool, and this pool is available to finance the healthcare needs of our Kenya. In addition to this, the judges also lauded the benefit structure and a lot of things that were done to ensure we get where we are. They, however, raised a concern about the process. They said public participation was not done to their satisfaction because some litigants said that public participation was majorly in English, and it was the inserts in the newspaper were in the font, the size of newsprint. We have taken this. The good thing is that when our lawyers appealed, to the same judge who made the decision to first declare the acts unconstitutional based on the pleadings of the litigants, the same judges granted a stay. We are in the stay period up to the 20th of September. And what this means is that we continue implementing SHA like business as usual until the 20th of December, when we are confident that the judges will realize that we have noble and good intentions for Kenyans and will support the continued implementation of these good projects. Thank you.
Thank you. Thank you very much for that straightforward answer. And perhaps something that, before I go to Dr. Wangia, shed light, you've mentioned about the digital and also a lot of the audience are speaking about corruption. So perhaps shed light on what mitigating factors are we having in SHA that is going to reduce corruption and increase transparency in the process.
Thank you very much, Dr. Amina. Corruption is caused by very many things. But one of the greatest causes of corruption is an enabling environment and two willing parties to participate in a corrupt act. What has been done in SHA, as the drafters of the SHE Act were coming up with the act, is to look for areas that were most prone to corruption. One of the areas, and I really laud the drafters of the act for this, is where NHIF, in addition to healthcare financing, was tasked with the task of accrediting and empaneling healthcare providers. Many of the employees of NHIF are specialists of healthcare financing or health insurance, and not specialists of standards of healthcare providers. So we got feedback that a number of healthcare providers had to go through very rigorous process, some of which could be very fertile grounds for corruption. This responsibility was moved away from NHIF, now SHA, and taken to KMPDC. The second areas of corruption were identified to be the intense human interface in the processes of admission, benefit administration, and claims processing. SHA will be a very digitalized organization. And what this means is that without a lot of human interface, it is humans that cause corruption, then the amount of corruption our vision is to eradicate it completely. But if not eradicated completely, then heavily minimized. Thank you.
Thank you. Thank you very much. In summary, digitization will play a key role in increasing transparency. So hopefully we will have a lot of that. And the fact that KMPDC has been given the empanelment will also assist a lot with that. Dr. Wangia, so what are the wins? You know, everybody is asking, we are paying 2.75. What is new, and what is the wins, and what does the future look? because I also heard you say we will get better with time.
Yeah, so thank you, Dr. Amina, for that question. And I would want to answer that question by reflecting on what happened, or I would say what went wrong within NHIF. Given that a lot of the either tariffs were either not based on data, some actuarial analysis and all that, the fund was actually, I would say, unsustainable. And specifically, we know that I would like to touch on the issue of the emotive enhanced schemes. And I know it's an issue that civil servants have raised, but the truth of the matter is that the benefits that were being offered by under some of these enhanced schemes were not commensurate to the resources given to the enhanced schemes. By the enhanced schemes, say by Public Service Commission, or mainly government entities. So most of them were government entities. So what used to happen is that most of the benefits, actually most of the resources used to since it was one pool, and the pay is one, some of the resources from even general contributions could be used to pay for some of the civil servants' bills. So basically what I'm trying to say is that, and based on even the history that CEO spoke about, that previously it was more or less, only bed charges. A long time it just used to be kitanda, but then we brought in all these benefits, but we never changed the premiums. The premiums just changed. The change was not significant. If you remember, we used to pay around, was it 160 or 360? Then it moved to 500, but the benefits had grown. So for now, what from SHA, at SHA level, there is no way we can actually offer less than what NHIF was offering. But we have to face the fact that then we need the adequate resources. So to start with, probably, maybe we know even as Kenyans, fewer people will register, therefore we'll have less people within the pool. Most of the people who will register quickly are the ones who maybe have chronic diseases and they are enjoying the benefits of NHIF, so they'll register quickly, followed by the people within the formal sector of whom this will be a statutory deduction. So what I'm trying to say is that that is partly the reason why we couldn't offer all these services, because the reality is that all these services have a cost to it. But otherwise, nonetheless, there's a number of new things. We never used to offer optical services, but now we are offering optical services. We never used to cater for the kidney transplant, kidney post-transplant immunosuppressants, but now we are catering for that. The surgical package has significantly expanded. If you look at the surgical package has expanded, the rates for reimbursement have also improved. Specifically, I would like to touch on Linda Mama. Like a normal delivery at level 2 was being reimbursed. As much as people like talking much about Linda Mama, but imagine at level 2, we are still reimbursing now, because Linda Mama is still on 2,500 per delivery. But now we are saying, irrespective of your level of care, we are reimbursing 10,000. So you can imagine this level 2 who will be, making claims of this 10,000. In no time, there'll be almost center of excellence in delivery of at primary level. So those are some of the wins that we had. Things to do with palliative care. Yes, we are paying for the bed, but initially it wasn't covered. So those are some of the wins I can say in a nutshell we have. Otherwise, improved rates, but then we have maintained. There is no benefit that was in NHIF that has been taken away. Back to you, Amina.
Sorry. Thank you. Thank you for that, Daktari. And maybe just to expand further, because I've seen a lot of questions regarding capitation, and perhaps you can shed light between capitation, the difference between capitation and paying for services. As you've mentioned right now, Linda Mama, we're reimbursing for normal delivery 10,000, and capitation though, we're paying capitation 900 on a facility. A lot of people are asking, how are we going to offer quality services on this? But perhaps you can shed light on the differences on how people come up to capitation, because it's population based and the other one is service based. But perhaps you can shed more light there.
Yeah. So thank you for that. For capitation, the initial discussions, and I mean, we have had many engagements with different stakeholders. So the initial discussion was to have a population-based capitation. And what does this mean? This means that we look at a primary care network, and maybe in case there are people who are not in the health sector who have logged in, I'm sure there are also a number of people. A primary care network means that you have a facility which is considered as the hub, mainly a level 4, what we used to call the district hospitals. Then below the district hospitals, they have their children who are now the health centers and the dispensaries, and this whole network is meant to work as one. So we all know facilities are what we call catchment areas. So even a primary care network will have its own catchment area. And therefore, the government would capitate, the fund based on the catchment area of that primary care network. And therefore, anyone who, you could go and seek, so long as you're within that network, you could go and seek service here or there. Then reimbursements would be based on some disease weights or disease weighting. But then we also realized that also when you're starting something new, we had not piloted this approach. And when you're starting something new, it's not good to, go full blown with it. So we say that for this first 9 months, which is from October to June, we will still work on capitation. And this capitation is the usual capitation. So someone will select a facility and we'll capitate that facility based on the people who have selected that facility, and they'll be able to seek services. So the assumption is, and for it to make business sense, based on our data, you need to have at least around 300 people capitated in your facility for you to clearly say that there's a chance that 2 people will fall sick, yet I got money for 300 people, for instance. That's just an example. Otherwise, if you just have like 20 people capitated in a facility and 5 fall sick, they'll drain the entire fund. So it's always good to look at then what is that minimum that you can you can put in. And we acknowledge also that there are those extreme counties in the extreme areas where you may not find the numbers. So those are special conditions. Those are special conditions to be factored in. But for the normal facilities where you have just a normal distribution, then the capitation is what will work. Eventually, when the system is really mature, and I'm not saying the digital system, I'm just saying the health system, as we mature, we're really hoping that you can even get into just paying for the service and just playing around with the rules and clinical protocols or guidelines, and saying if you have a pneumonia, this is the treatment, then we just pay fee for service. But for now, even in terms of ease of administration at primary level, we know even at primary level, most people, either for those who have gone to dispensaries, you'd find them maybe with one nurse. You won't tell this nurse key in 1 glove, 2 granulars, they'll never see the patients. So even for the ease of administration at primary level, it's easier just to use that. Then with capitation, once you have capitation, it's also The whole idea of capitation is that you can use those resources because it's for a defined group of people. You can use those resources to do public health interventions at community level that will actually prevent the patients from coming to your facility. So not seeing patients in your facility doesn't mean that you are not working. Probably you have chosen to go out, you're doing outreaches, you're making sure people are, bushes are cut, people have toilets, people have water, and therefore they won't come to your facility with diarrheal diseases or malaria. So that is the whole aspect of, or the whole importance of capitation, having the money in advance for you to be able to do these interventions and even prepare in advance, and also the ease of administration at that level. Back to you, Dr. Amina.
Thank you. So the next question, I'll direct it to Dr. Mr. Nani, the CEO, Elijah Washira, in regards to the 2.75%. And basically, there's a lot of questions around it. And the main one is actually the justification around it. Perhaps you can shed light into the deep analysis and the deep thinking behind the figure.
Thank you very much for the very good question. I will try to make sure that I address my audiences as clearly as I can with this one. Now, to be able to come up with a premium, you establish the healthcare costs during a period. And the intention here was to come up with equal distribution of the finance burden in our country. You will realize that in the old NHIF system, people who earned very high incomes paid a very small percentage of their incomes into NHIF to get service, while people who earned very low incomes paid very high percentages of their incomes into NHIF. To put this into perspective, I want us to look at a premium, the NHIF premium of 500 shillings a month as an example. For the person who earns 5,000 shillings every month, then 500 shillings is 10%. But for the person who earns 10%, 10,000 shillings, this now comes down to 5%. And if you go to the person who earns 100,000 shillings, the percentage begins to become smaller and smaller, because 500 shillings out of 50,000, for example, is 1%, and 500 shillings out of 1,000 now starts to become very negligible percentage. So the very first objective was, how do we make contributions into the healthcare financial equitable? And then the second question was, how much will it cost to deliver this healthcare per household across all households in Kenya? Then the third question, that again, data was available, and this data now a lot of our health records. So the third question was, what is the total income of households in Kenya? And that is where now a figure was arrived at, that if you divided the total cost of delivering this healthcare across the country to the total number of households, and you divide that by the total income, then this is what gave the 2.75% of all our incomes. I think it's important that I bring this to the fore. For people earning low incomes, then you realize that 2.75% is way lower than the 500 shillings a month they were paying earlier. Looking at the number of households from Kenya National Bureau of Statistics, it is anticipated that 54% of our households across the country will end up paying less than the 500 they were. Only 46% will pay more by beauty. So it was a scientifically generated number, and all Kenyans are encouraged to contribute, partially because they will benefit, but more importantly, because we all are contributing to a pool to ensure that our brothers and our sisters are able to access quality, affordable, reliable healthcare service. Thank you.
Thank you. Thank you very much. In the interest of time, I will ask Dr. Wangia the last question, summary of one of the repetitive questions. What happens in the event that you've exceeded the limit? You've explained that you've given us a brief overview of all the tariffs, and case in point, optical, dental. And why I'm picking dental is because there were a lot of questions being asked on the coverage of dental and if it is sufficient. What happens in the event that it's not sufficient? What next? And perhaps you can put it in the context of when you're in a public hospital and also when you're in a private hospital. Thank you.
Okay, thank you once again. The thing about social health insurance or the SHA funds, it differs a bit from what usually happens in private insurance. So for private insurance, you'll be told your outpatient cover is maybe 40,000, your inpatient cover is 1 million. And once you exceed that, then you cannot access services. But for social health insurance, for each and every benefit, it has its own limitations. So you may say, for instance, maybe you are a cancer patient and you need a surgery. So probably you have exhausted your limit and under cancer of 400,000, which I said. But then if you need a surgery, you have not utilized your surgery package. So the limits are actually as per the benefits. And therefore, anytime you exceed that limit for that benefit, so for that particular benefit, then you'll have to top up. And I've seen also a question within the chat that does it mean that people will really will still have to significantly pay out of pocket? In the spirit of equity, they are the facilities, and we are government. We always look at our government facilities. For the government facilities, it will be a walk-in, walk-out, apart from some specific services. For instance, ICU, because ICU, we know that we have said for now, given the resources that we have, we'll only cater for a daily rebate, and same as inpatient. So if someone gets into an ICU, then they'll have to top up the rest. But for the other cases, like, for most of the other cases, it will be walk in, walk out. Now, as you move to other facilities, because we also acknowledge that within the private sector, there are many dynamics in play. One, most of the time, being private sector, probably they have the most advanced, say, equipment, and they have actually bought the equipment. unlike in government facilities where we all know, we have heard of this MESS program and, whichever other program, and Dr. Amina knows them better. The government actually has been giving public facilities this equipment as grants. Look at the human resource. The private sector pay for their human resource. On this other hand, within the public sector, the human resource are paid for by Exchequer. Think of even the land, even construction, for you to construct a facility. If it's a private sector, they are likely to have gotten a loan. Maybe they are paying even heavy interest, while on this other side, it's still Exchequer. So what we say, whatever tariffs that we have are comfortable tariffs for a public facility with all that put in mind. And we are saying for a private facility, we will still give the same, because that is that is the cost, a comfortable cost for at that level. But if a patient needs, if their rates are higher, then the patient will have to copay. But for that Kenyan, that mama mboga, who doesn't have any other way, they will be able to access service for sure. And and I mean, even just generally in life, it's usually not a good statement to say, but we can never be the same. And that's why some people go to Kibanda for lunch, others go to Kempinski. All of it is lunch. At the end of the day, all of you will be full. It's just the environment and, I mean, it's life. We can't all be at the same level. But you're saying, for universal health coverage, you look at equity, and therefore for anyone, for all the people, they'll be able to access a service. And if you choose not to access a service, maybe at a certain level and go to another level, we will still pay for that service. But then anything over and above what we have committed to, you'll have to copay. And this didn't used to happen in NHIF. At some point, for the higher private level facilities, it used only to pay the daily rebates. But now we are saying for whichever tariff that we have committed to and benefit you have committed to, we'll pay it at whatever level, then there'll be the copays. I think I've responded to the two together.
Yeah. Thank you, Dr. And I hope the audience have understood. But before we leave, because it's past the time, parting shots. Dr. Wachira.
Thank you very much. Call me Wachira. Parting shot. This is a good initiative. The court said that this is a noble initiative where we want to encourage as many Kenyans as possible to be insured. The one question I will ask all of us, especially those of us who drive, what is the color of your airbags? And I'm sure many of you will want to say, I want a car with airbags, but you never want to see the color of the airbags because by the time you are seeing them, you are in an accident situation. Let us encourage all Kenyans to register with SHA, and it is a simple process of *147#. I repeat, *147#, and then you follow the prompts. For those who have access to internet, again, it's a simple process where you go into the registration portal of SHA, www.sha.go.ke, and then you go to the registration tab and follow the prompts. It is easy steps, it is simple, but it is going to ensure that at the time of need, you do not have to incur those very high unnecessary costs. I'm also calling upon us to encourage our relatives and even send to our WhatsApp groups the need to register, because the same people in our WhatsApp groups are the people who will call us to assist them, to pay huge bills, whilst they would have paid small amounts as low as 300 shillings and saved the embarrassment and inconvenience of the high bills. Thank you very much and have a good night, everyone.
Yeah, so from my end, I would just like my parting shot would be that benefit package is meant to be progressive. And the more we implement, the more we implement, even the interventions we put in place, will free up, say, resources. And I would give an example as it's a parting shot, that, for instance, with the high investment in primary healthcare, right now, will yield the fruit of this investment maybe 2, 3, 4 years in 4 years' time, because then the cost required at that level will have gone down. The use of digitization alone will also enhance efficiency and therefore will free up resources that probably were getting lost through maybe fraudulent processes, and therefore will be able to expand the package. And the third thing I would like to say is that there is no perfect time to start. If you wait for that perfect time, it will be like that meme I usually see of the 3 old skeletons of women who sat on a bench waiting for the perfect husband. You die sitting. So the thing is we need to start with whatever we have. Let's own this as a country. Start off, let's learn together. And I can't promise that it will be perfect on even October 1st, but the whole point is to start. We start, then as we implement, we get better with time, we learn, we collect data, we look at the habits, we see, what the savings are like, then we get better. So that would be my parting shot.
Thank you, CEO Wachira and Dr. Wangia, for your kind time and giving us a good overview. To the audience, I realize there are so many questions that have gone unanswered, but I also fairly believe the vision is more clear right now. Dr. Wachira has explained to us the thought process and the noble initiative of SHA, where it has come from, and that SHA is a bigger body that is also covering Primary Healthcare Fund, the SHIF, and together with the Emergency Fund. Dr. Wangia has given us a good indication what's the difference between benefits and within the tariffs. Listen to it again, especially for the tariffs, where Dr. Wangia has clearly shown word by word on what we are going to benefit and who are the wins. Of course, it's not a perfect process, but we are all going to get better, and we're going to get better together. So the series, as I had mentioned earlier on, will be 3 series. Tomorrow we'll be looking at the digital arm of the UHC agenda. Health financing is really crucial. We'll try and see if we can discuss internally if we can have another session on this to expound and answer most of the questions. Tomorrow we'll have the digital team coming in. As you're aware, 4 laws came into practice. One of them is the SHA and the digital, 3 laws. And the third one is the primary health. So the third day we'll be discussing on primary health care. So you can read up. We'll try and tackle the cause so that we can be able to understand and the operations will make sense out of it as we go. So thank you very much for tuning in. Kindly leave your comments with the Nelson and team. And thank you again, Dr. Wangia and CEO. Good night.
Thank you and good night. Bye.